Hello, folks. Welcome to the MMOA podcast. My name is Dustin Jones, and today we are going to talk about all things annual mobility assessment. I have two very special guests here with me, Dr. Mike Puthoff and then Dr. Victoria Hamby. They are a part of a team that is really promoting this annual mobility assessment, this concept, the research behind it. And I'm really excited to hear from them because I think this has huge implications for our effectiveness as professionals, but then also for everyone, kind of across the setting of how we can identify folks that need our services, that need our care. So quick introduction. Dr. Mike Puthoff, physical therapist professor at St. Ambrose University. He's the chair of the APTA's Academy of Geriatrics Task Force. Dr. Victoria Hamby is an assistant professor and director of clinical education at the University of Louisiana, Monroe, and she is also a part of the APTA's Academy of Geriatric Task Force. And with their forces combined, they are really giving us, I think, a huge opportunity to maximize the impact in the people that we're serving. So both of y'all, thank you for taking some time out of your busy schedule to hang with me.
Dustin.
Thanks for having us.
Awesome. So the annual mobility assessment, if you've been to CSM this past year, you probably saw a pre-con, you've probably seen it at some different conferences. There's a recent perspective published in PTJ and Physical Therapy Journal. And this is, I think, just, it's been years that you all have been working on this, but we're really starting to hear more and more about it. So let's start off. Dr. Mike, if you wouldn't mind to just kind of lay the foundation of, for you personally, what problem does the annual mobility assessment solve, and how have you seen that problem in your own life or practice? I'm very curious from that standpoint.
For sure. I think we can all think about that patient we've seen who is struggling to get out of the steps. They can't get out of their chair as well. They're just not moving well at all. They have the mobility limitations, and they say, "Oh, it's just seemed to happen in the last couple of years." And the reality is it was not the last couple of years. This has been going on for 5, 10, 15 years, and no one has addressed it. No one's looking at those subtle changes, those subtle losses of mobility and function. And, it's ridiculous, right? If you don't go to your dentist and wait until you have a rotten tooth before he or she does something. Your doctor puts you on medications before you have a stroke if you have high blood pressure. But who's looking at mobility? And of course, that should be us. That's what we're the ones who should be looking at that. And that's really where the annual mobility assessment comes in. And this idea of an annual visit has been out there for years and years, but the mobility assessment really focuses on mobility alone. Those other factors that you might do in an annual visit are also important, but really focus on subtle changes in mobility. And we've adopted the term preclinical mobility limitation. And we didn't write that term. That term's been growing in the literature. But these are the people who they can still climb the stairs, they can still get on the floor, they can still walk a mile, but they're saying, it's just a little harder, it's a little bit more difficult. Those are the people we're trying to capture. So how we're trying to capture that, asking questions about that, self-report changes. We've included 6 different measures, physical performance measures, to try to capture those subtle changes and compare them to normative data. And then afterwards, talk with them, coach them through how to make some changes in their lives. And that can be as simple as, let's add a couple exercises, let's get you in a community-based program. Or in some situations, you need to get back to your doctor. You need to go see a physical therapist. So for me, that's the driving force. Those people I've seen in skilled care, the people I've seen in the hospital, who it's like, we've waited too long.
Yeah.
I can help you, but it would have been a lot better 10 years ago if we started making some of those subtle changes.
Yeah, man, that speaks to me, especially with a lot of my experience in home health, that the vast majority of folks that I've worked with, it was perceived it to be preventable suffering, which has motivated me to, get into outpatient and fitness. But that is something that we can have a huge impact on. So Dr. Hamby, I'm curious with this annual mobility assessment. So if you're a geriatric clinician, you hear annual visit in healthcare, right? Many of us are going to think about the annual visit or wellness check that a lot of these folks are going to get with their primary care physician. How is this different? And is this annual mobility assessment being targeted towards just physical therapists or other healthcare providers to execute some of these measures?
Well, the annual mobility, the annual Medicare visit is typically performed by a physician, but can be performed by many other healthcare providers, including physical therapists. But we talked with several people that do annual Medicare visits, and there's only 2 questions about physical function, and they just ask about it. They don't assess it at all. So that's why the annual mobility assessment would be something where we actually assess the patient performing these physical performance measures and actually see how they're performing and able to give them very specific feedback on ways to improve their strategies. And so we want us to do this. We, as physical therapists, we are movement specialists, but we're not saying that only physical therapists can perform the annual mobility assessment. We want it out there. We just want our older adults to be able to be assessed in some fashion every year so that we can intervene earlier. We're typically a rehabilitative career path. We get our patients downstream after something has already happened and there's already a mobility limitation, and we want to be able to identify these folks before they have had an injury or a fall and intervene earlier.
Yeah. And I know you've got a lot of experience like in outpatient orthopedics, and I think about that setting a lot because for most folks, their primary driver for those services, it may be like a mobility limitation, but for a lot of folks, it's pain, right? Like they've had a surgery, an injury, they're hurting, they're coming to PT for that. How have you seen this assessment play out in that setting where mobility concerns may not be the primary force for them to come see our services? Like how are clinicians having this conversation and bringing light to this assessment when folks are coming to them for pain and not necessarily mobility problems?
Well, go ahead, Mike.
No, you go ahead. You go first.
I was just using this example with my students for someone that comes to you for an injury that maybe happened because of a fall or something that they were doing that they had changed their ways of functioning that caused them to have an injury that led to pain. That would lead you in the subjective to perform this assessment. And we should be doing this anyway. Our study questions should be utilized at 65 and older anyway for anybody that's coming to us. So just changing the perspective of the clinician that you're not only looking at the injury that's bringing them to you or the problem that is bringing the patient to you, but looking at them as a whole person and every system that is being affected as they age, and just really flipping that script and thinking about the opportunity to provide some other types of assessments and education to the patient, regardless of what brought them to you.
And I can add an example to you too, Justin, or Dustin. ATI, they have taken, ATI Physical Therapy, they've taken a version of this, pretty close to the annual mobility assessment. They've been consulting with us a little bit, where they're using some of these screening tools and this philosophy around the annual mobility assessment, and then doing that for every patient that comes in. So if they come in for shoulder pain, they're doing the annual mobility assessment or a very, very close version to that.
Okay.
We also have another colleague who works in the VA system. She is using the annual mobility assessment. They have clinics where the veterans come in and they're using that in part of their practice. So we are seeing it being implemented in some clinical areas for sure.
That's awesome. So let's get into the assessment. So you mentioned 6, functional outcome measures. Could you kind of explain what those are and just kind of go through what the assessment looks like?
Sure, I'll take that, Mike. So we have 6 physical performance measures. We start with usual gait speed as kind of the 6th vital sign or functional vital sign. And then fast gait speed is kind of that functional reserve. A 30-second chair stand for lower extremity muscle strength and power. The 4-square step test for obstacle clearance and multi-directional stepping. And then the tug for overall mobility. And then the tug cognitive for that divided attention task.
Awesome. So a lot of outcome measures that many of us are familiar with. I love the dual cog tug, which for anyone that has not experienced that themselves or use that on some of your patients, that one is very eye-opening in terms of how that can impact performance. Have you all noticed anything with interpretation of scores in terms of are you all using some of the kind of standard cutoffs that we'll typically see, or is there anything kind of different that you're seeing when you are utilizing a lot of these measures, maybe a little more upstream than what many of us are using these outcome measures? Like if I'm in home health, for example, any trends?
Yeah, so I think how we're really promoting the scores to be used is to compare against normative sex data. So compare 65-year-old men to 65-year-old men. So we have found 10-year normative data, pretty good data for the most part. We're in the process of updating that data, doing a systematic review, meta-analyses to make sure we have the best data, but not waiting until their gait speed gets down to 0.8 or even 1.0, saying, you're walking at 1.2 meters per second, but that's less than what you should be based on your age and gender. So we use that. And then in my research study, we've measured it at 0, 6 months, and 12 months. And that's been very insightful. Been able to show people like, hey, you've made a 0.1 meter per second improvement in your gait speed, or it's gone down a little bit. What's been going on? And that leads to some good conversation. So I think what really makes it key is the age normative data and the changes we can detect over time if we can get people to come in on an annual basis.
Awesome. What is there a composite score with that?
We actually have a report card that the participant goes home with for the 6 measures, and we use that normative data that Mike was talking about and put it across a red, yellow, green, like a stoplight, because it's very understandable for everyone. And if you score in the green, that means you are at least a half standard deviation below the mean and above. So you are in the green category, you're doing well like your peers. If you are between half a standard deviation to a full standard deviation below the mean, we call that the yellow category. So you're starting to fall into what we call this preclinical mobility limitation, and we need to make some active changes to get you back into the green category. And then a full standard deviation below the mean, we consider the red category, or a mobility limitation is already present. We use our clinical judgment if they're, right on the cusp of red and yellow or yellow and green, because we don't know that these are the exact correct ways in determining whether someone's in the green, yellow, or red. But we're using it to inform our decisions. We also watch how they are performing the measures. Are they very, very fatigued after fast gait speed or 30-second chair stand? And that is helpful in giving the information whether they're on the cusp of one color or the other. And it's very meaningful to them because they can understand it. We have these wonderful report cards that show where their peers are functioning and where they're functioning. And so they can see, like in our data, we did an annual follow-up actually yesterday. So I was able to compare participants from last year to this year. For example, I had some that improved in all 6 measures, and they were so excited. And then we talk about physical activity guidelines, and we were discussing with one participant, and she said, well, I just kind of got lazy. I don't go as much. Well, when we got to the report card, she had fallen into the yellow on 3 of the 6 outcome measures. And so we were able to say, well, you did just say that you had gotten a little lazy and you weren't walking as much. So look where this is, shown in your performance. And so she was able to say, okay, I need to start walking again a little bit more.
Man, how tangible that has to be, right, for those folks. And it brings all these numbers and data points that can just be very arbitrary and make it really hit home. That's awesome. So I'm curious what the participants or the patients that have gone through this, like their perspective of it. And I'll just give an anecdotal point to an observation I've had. I've got to run the sustainable athlete fitness exam, the SAFE, at a few state games and national senior games. And I mean, it's a very different crowd in a way than general population, I would say, but they freaking love getting a score, seeing how they're doing compared to their peers, whether it's a person literally beside them or what's shown on paper in terms of norms and their age groups. What do you see in the folks that you all have applied this to? Do they really get into it? Or is it something that they're like, whatever, okay, I'll do this? Like, what's the general perspective of it?
Let's you answer that, Victoria. You did the poster at CSM this year on that, and I can follow up with it.
Yeah, so we do a little questionnaire afterwards on how they interpreted the assessment and what it meant to them, and scores were out of 5, everything scored well above 4 out of 5 for that they agreed with how meaningful it was, or that it was important that they would take the information and make a behavioral change. They receive it very, very well. And just in talking with participants, they are just thankful that someone is thinking about them. And providing education for ways in which that they can improve, because a lot of older adults think that they're doing the right things, and some of them are, but other times we are able to say, well, hey, why don't you try this? And we educate them in ways in which they can increase their activity that doesn't cost them extra money or a lot of time. Just our background as physical therapists and how we can show that you can do plenty of exercises with no equipment and not a lot of extra time that they just don't think about, because the typical person in the general population, not just the older adult, thinks you have to go to a gym, you have to spend an hour, 2 hours, I have to set aside all this time, when really you can break it up into bouts of activity, and just providing them with that, education, and it really empowers them to say, I can make a meaningful and sustainable change.
And Dustin, I agree with everything Victoria said. I can give you the flip side that I've kind of seen a little bit here. So if our 12-month follow-up, I've had a handful of people not want to come back because they didn't do what they said they would do. So there's a little bit of an embarrassment factor, and really encouraging them to say, like, this is not about making you feel bad. This is not about punishing you or anything like that. Let's just talk. Come on in. We want to see those subtle changes. We want to talk about those things. So I think that's one of the things when it comes to preventative services we see in PT and elsewhere, where the really healthy people want to come in and get a pat on their back. But how do we and I don't have an answer to this. How do we capture those people who really, really need to see us, right? I mean, go to the grocery store. You want to hand out business cards. It's like, come and see me, come and see me. So we have to make it inviting and not make it like a competition, or, again, we have a report card, right? But we have to make it feel like it's not A, B, or C. It's how do we make improvements for you? So that psychological side is something we have to keep thinking about through all this process.
That's such a good point. And I think the fact, I don't know the dynamic, of some of these folks that are getting the assessment. Some folks, in the study may be getting paid or what, I don't know what the dynamics are, but like for someone to say, I want to do this. And even if they, in the back of their mind, they know, all right, I'm not doing as well as I think I can be. And then they make that huge jump to show up, to go through these outcome measures, to get scored. And it makes me think about the huge gap that we see within our profession, but then also within fitness as well, of the services to support those folks along that journey, right? Beyond like the educational resources and the guidance that we can give, but to have that professional that can walk alongside them and really guide them to execute on a lot of these things that we know to be good, which when we are able to provide that and usher these folks through this mysterious land of fitness, and that's able to handle all the complexity and all the things that they have on board, the results that we can get are pretty amazing. What would you say to clinicians that run this assessment in terms of like that scenario, right? Like when, okay, we've got these yellows, we've got these reds. What do you tell folks to maximize the odds of like, we're going to see change, like behavior change that are going to help these people improve upon these things? What typical guidance do y'all give clinicians?
Yeah, we've been using brief action planning. It's a kind of a motivational interview and informed process. You had Mariana Wingood on a few months ago, I think it was. She's really foundational in bringing this to physical therapy, but it's a pretty simple process to learn. But what you do, you get to the end of the results and say, how do you feel about this? I go through this, and I've done it, I think, 120 times now or something like that with people. And it's like, okay, here's a red or yellow, whatever. How do you feel about it? Just put it out there and let them self-identify and say, what do you want to work on? What's important to you? And you let them set the plan. You let them do it. You support them. You try to get them to have a SMART goal. You try to see what their confidence is. Can you bring up their confidence level? I have found that's been pretty useful, as opposed to me coming to the end and saying, okay, you scored poor in your 30-second sit to stand. Automatically, here's a list of exercises of sit to stand and squats and deadlifts and things like that. Let them ask for it. Let them say, this is what I'm willing to do. That partnership, walking alongside them, therapeutic alliance, all those, whatever term you want to use there, you have to be walking along with them. They're going to get better buy-in, I believe.
And it's so simple, but I don't think it's our first move for so many folks, right? Like we're so used to handing out 3 pages of the HEP and kind of this dictator role of, you will do this based on these results. And we all know how that goes. At least as a home health clinician, I saw how that went.
Yes.
As I saw 13 stacks of HEPs that were given to folks. Victoria, do you have anything to add to that?
Yeah, I just wanted to say last year when I performed this assessment that we just did the annual follow-up yesterday, we weren't really doing the brief action planning back then. We did still have a counseling session. We had different areas like here's an HEP, here's a community service that you could join. Here are a list of places you can walk for free, outside in my area. We made, everyone needs to make a local list of available resources. But we moved into this brief action planning. And so yesterday, it looked very, very different. And like Mike said, letting them take ownership. It's also helpful when you're discussing their physical activity guidelines, what they perceive as what they're doing for aerobic activity or strength or balance. They may be, misinterpreting what they're doing for those three areas and say, well, look, your heart rate wasn't really getting up during this activity, but you were working your muscles. So I think we need to find another way in which you can get your heart pumping a little bit more. Let's take several brisk walks down to the mailbox during the commercial break or something like that. Just helping them understand that what they're doing may be good, but it may not be exactly what they think that they're doing, and empowering them again in ways in which they can improve their fitness on their own and in ways in which they feel is tangible and doable.
Man, how many times have we asked people, all right, do you do any exercise or get any physical activity? Like, yeah, I exercise all the time. And then you peel the onion back, right? And then you realize they're walking Scout, their dog, with the tiniest bladder ever, and they're walking 10 feet and then stopping so the dog can pee on the bush, and then they're walking another 10 feet. And it's like, okay, that you are moving, right, but not to the extent that may be as beneficial as possible. I think that's such a good point. And what I've seen too is like, it's not just our patients, right? I think it's us, like as clinicians. Like I think our profession, when we think about physical activity guidelines, we're very comfortable telling other people that they need to hit these numbers, but oftentimes we're not even hitting them. We may not even be achieving the intensity or getting that 2 times a week of resistance training. And I'm saying this like I'm right there. Like it's something that we need to practice first before we're trying to tell other folks, what they need to do. I think it's a big issue within our profession, but I'm very excited because y'all could probably attest to this. Just the narrative around exercise and physical activity has just shifted so dramatically in a relatively short period of time to where this is on the forefront of a lot of clinicians' minds. And that's exciting to see. Yeah, I graduated in 2011, and exercise was like, it was just corrective or, therapeutic in nature. We weren't talking about getting people as fit as possible. And now it's very different conversation, and largely thanks to a lot of the work y'all are doing. So with this annual mobility assessment, someone that's listening, watching, that's like, man, I really want to implement this into practice. I want to kind of get into just some very practical kind of advice and then point them in the right direction. So let's say I'm an outpatient clinician, busy, outpatient ortho. I'm seeing 15, 20 some folks a day. How should I implement this? Should I try and kind of bring this into the conversation with Betty that's seeing me for her neck? Do I also think about, hey, is this a service or we're trying to schedule folks like, hey, all the patients I'm seeing, I want to see you back here so we can do your annual mobility assessment. Kind of what practical advice would you say to that busy outpatient ortho clinician to work this into their existing workflow?
I think there's a couple different ways to do it. Like you said, if Betty comes in and she's there for shoulder pain or neck pain, and you look at her and say, it'd be helpful to do this, you can write that into your plan of care. And I would say I'm in academics, right? So I'm not in the clinic every single day. But we've talked to the private practice APTA Academy about this a little bit, and other practicing clinicians using the physical performance CPT code. I had to look it up, 97750. Okay. You can build that into your plan of care and say, I want to test mobility and I want to do this and that. And the advice we've gotten from private practice is that, that will probably work. If you can say, I'm concerned about Betty's mobility, I've watched her come to this clinic, I want to also address this alongside of this. If you're going to do it as a standalone, the path for Medicare insurance reimbursement is not as clear. You could offer it as a service, an extra service, a community service, that sort of thing is a way to do it. Maybe, Victoria, you can talk about how you guys have done it, maybe, I think, as a community outreach, because that's what the approach you've taken too.
Yeah, so we actually do it at our university for the Physical Therapy Day of Service every year, which happens in October. So it's a free community event. And then 6 months later in our curriculum, we bring it out to senior centers, which is hopefully going to set us up for a 6-month follow-up and an annual follow-up every year. But clinicians can offer that as a service as well. But the 97750 code has worked for clinicians I've worked with. It's the same code that people use for FCEs and return to sport, ACL testing.
Okay.
It just has to have a written report, and it cannot be performed on the same day as your evaluation, because any of your physical performance measures would be, included in your evaluation code. So,
okay, that's helpful.
It looks very promising moving forward.
Yeah, and I can only
we have
imagine.
A colleague.
Go ahead.
Oh, I was going to say another colleague, Valerie Liebert, she's up at St. Scholastica University. She is doing a mobility checkup, which is very similar to the annual mobility assessment. And we have good communication and have been talking things over. But she just published a research study where she was in a physician's office and she would see them right after their annual Medicare wellness visit. And she has another colleague, kind of secondhand knowledge here. She worked at a neurologist clinic, and she would do annual checkups with the patients there. Like she was in the doctor's office doing that way, who needed to get a CPT, who just needed some little guidance on things. So there's lots of different pathways, I think. And I don't know if one is better than the other. We're encouraging all of them to be explored at this point, really.
Man, I'm thinking about with Hyphen of a community event. I mean, almost like a workshop where we have folks come in to run. I mean, just think of as a private practice, right? Like you run folks through that AMA, the annual mobility assessment, and identify some maybe yellows or reds. I mean, the odds of that person seeking your services as a physical therapist goes up pretty dramatically. For those that would want to do kind of that community-based effort, what do you advise in terms of like staffing? Like if I were to want to take people through those 6 performance outcome measures, could I take multiple people through at the same time? Is it strictly one-on-one? Have you all done it in kind of the group context?
Well, I'll speak to our setup. We utilize students. So we have an admin at the welcome table to do the intake form. Students take them around the assessments. And then we have clinicians doing the brief action planning at the end. So, it depends on how busy it is or if you set up times ahead of time. So at our PT Day of Service, people just show up. And there's obviously a wait time, as they're going through the event, but it's a fun time. And we also have young people coming in and doing the event and just trying to figure out what physical therapy is all about. And then in our senior center, we sign up ahead of time. And we did 10-minute time slots. Probably more realistic is 15 to 20-minute time slots. The physical performance measures take a very short amount of time. It's the intake form that takes quite a bit, which can be, emailed ahead of time if you know who's coming and can get it to them ahead of time. And then, of course, the counseling afterwards. Yeah. And education is the more important and timely,
Got it.
And I'll put a plug in for the APTA Geriatrics website. And this is open to everyone. You don't have to be a member to get to this information. We have a manual there. It actually has a chapter or a section on how to set up a community-based event with advice about how to lay things out. And this is what worked for us. It has all the report cards there. It has the interpretation guide. So there's a range of really good. If you're thinking about doing it, that should be your first stop, the APTA Geriatrics website, and reading the manual, the instructions. And of course, we want you to be as consistent with where the data is coming from. So we have it spelled out, how to lay out the course and how to measure it, what the cues are and everything like that.
Perfect. And I'll be sure to include that link in the description, the show notes as well. Would that be the same link? Is that kind of the go-to spot to learn more about the annual mobility assessment in general? Okay.
Correct. Yep. Mm-hmm.
Awesome. All right. So I will be sure to put that. If y'all are watching on YouTube, listen to the podcast, wherever you're consuming this, just look in the description. You'll find links to that. I'll also link a couple of the publications that are related to annual mobility assessment as well. And I hope everyone listening, watching has gotten some good ideas and some ways that they can implement this, and even just to have that perspective, right? To see that it's not this overnight event that people have mobility limitations. Sometimes it is. It may be some traumatic injury or whatever, but by and large, it's years or even decades ahead of time. And the quicker we can identify and implement a care pathway, the more we can prevent down the road. And that's really exciting, and it makes me very proud, to be a physical therapist, to know the extent of the impact that we can have is kind of beyond comprehension. I feel like, not to overstate it, but I appreciate y'all taking the time to share your perspective and just all the hard work that goes into this. I know many people see a publication and be like, oh, that's a cool paper. But that's years upon years upon years and hours upon hours of work. So I appreciate what both of you all do here.
Thanks for having us, Dustin. It's been great to talk with you and talk a little bit more about the annual mobility assessment.
Awesome.
Yeah, thank you so much, Justin.
All right. All contact info, websites, all that fun stuff will be in the description. Appreciate your all's time.